includes a couple of case vignettes. Actually, it's all the same case, but you know the case evolves over time, and I'll describe how. But essentially, the story begins with the case of you, the healthcare worker, working in a busy HIV clinic. You've seen over 200 patients in the clinic in the last week. You're short-staffed, and one of the other members of the healthcare professional team, one of the other healthcare workers, does not turn up for work and hasn't been at work for the last 10 days. So the case begins with that sort of clinical scenario where you're faced with a substantial burden of disease and you're short-staffed, and you, the learner, has to make a phone call to your colleague to find out what's going on.
Yes.
So the case subsequently evolves, and it transpires that particular individual tells you over the phone that they have symptoms suggestive of tuberculosis. You recommend that they get worked up appropriately, and then moving forward, the case addressed challenges of nosocomial tuberculosis. Let me just pause here so that Shane can move to the next slide. And just a quick reminder, if you are not on mute, be great to ensure that you are on mute so that everybody else can listen uninterrupted. Thank you. So the case covers a few important areas. So we begin with a role play of that phone call with a colleague who's absent from work. And this is an opportunity for learners to engage in communication with other health professionals and potentially address a scenario that might involve conflict. Although as the role play evolves, you discover that this person actually has tuberculosis. So we challenge the learners to try and determine what's going on, and that's really how the case starts. Moving forward, we then ask the learners to discuss how this patient may have developed tuberculosis, and we review the the risks for tuberculosis transmission. And in a discussion format, learners are asked to think about possible factors associated with transmission of TB to a healthcare worker, which is something that many of you see. And, both in terms of the infectiousness of the patient and the type of exposure, the duration of exposure, etc. And then the module pivots to talking about the TB infection control issues that need to be addressed to mitigate the risk of TB. And as any of you that are working in high TB, HIV prevalent settings, there are a number of different interventions that can be employed. Administrative interventions, environmental interventions, and personal protective equipment that learners can use. And so we ask the learners to refer to a CDC handout that gives them that information, and they can unpack those different learning activities for themselves. After that, the module pivots to thinking about the opportunities for quality improvement around TB infection control, and specifically we propose that you, the facilitators, use a template called the A3 template to help learners think through what are the possible interventions that could be employed to reduce the risk of TB transmission amongst healthcare workers. And the A3 template is simply a tool that's developed in the manufacturing industry, in fact by Toyota, to really sort of put details to a quality improvement agenda. So like many other quality improvement tools that we refer to over the course of the STRIPE training, this is just one that is used in manufacturing. affords a framework, a lens for thinking about where there are opportunities to improve quality, in this case, reduce risk of TB transmission, and then circle back on those interventions to see whether changing things made a difference. So learners spend about 10 minutes going through this framework and thinking of its relevance to their own practice. It's really just illustrative. It's the idea of getting people to think about a particular framework for quality improvement. So then sort of switching from the quality improvement framework, we ask them to sort of think, individually, have you ever experienced, being absent from work, and is there anything that can be, any reason for absenteeism that may inform why other colleagues might be absent? And again, the module sort of provides some narrative to describe why this is a relevant topic. And beyond getting TB and having to be off sick from work, this is really about trying to get the learners to think about, all the challenges that are put on healthcare professionals as they go out into the workplace. The things that make being a healthcare professional challenging, and the case evolves in such a way that we hear about a colleague who's been absent from work and has found another job and won't be returning to your clinic because he or she has found a job where the pay is better and the commute is shorter. So what we want to do here is ask the learners, have you ever experienced, this kind of scenario where a colleague has decided to leave work, or even you have, for one reason or another, and what are those reasons? Maybe it's the remoteness of the working location. Maybe the government has reassigned you to somewhere else. Maybe there are better opportunities in the private sector, or you have to follow your partner's professional career. We're inviting these learners to kind of think, big picture here. And I think the role of the facilitator is to encourage participants to consider, what other things that drive people out of the health profession, and then specifically, are there things that can be done to ensure that people don't leave the healthcare profession, and are there self-care strategies that would sustain their energy or motivation to avoid burnout? And so we want to ask people to sort of pause and reflect, personally on their own experience of working in clinics and hospitals and the challenges that they face. And then just to go back to slide 11, the objectives slide, we end this session by, thank you, this one. Thinking big picture, what health workforce strategies could be employed to increase the supply of healthcare workers and keep healthcare workers in the workforce for longer. And I recognize that most learners will not have experience of this themselves. Managing programs that are all going to be fresh out of medical school or nursing school. But what we're really interested in here is having them think about, what can be done to address healthcare worker attrition? And we pose a couple of questions. What could medical schools and nursing schools do to improve the supply of healthcare workers, to provide HIV care, and the role of the Ministry of Education in that sense? And then what can the Ministry of Health do to keep people in the workforce? And so I thought that this provides an opportunity to discuss, how do you create a safe workplace? What are bonuses or incentives that staff could receive to keep them working in less desirable locations? How is salary important in driving retention? What is the importance of career opportunities, etc.? So the case ends with sort of a big picture reflection. and trying to get the students to think through a sort of a bigger lens about the challenges of human resources for health in settings where HIV is a big problem. So I'll pause there, and again, just if there are some of you that are not on mute, by all means put your phones on mute, and I'll hand the hosting responsibilities back over to Cheyenne.
Thank you, Mike. Okay. Now I'm going to go back to 15. Jihan, can you test your audio?
How's that?
Great.
Perfect. Okay, so hi everybody, thank you. I will be talking about Module 15, which is really about pneumocystis pneumonia and traditional and complementary medicine. And this module came about from the fact that with PCP or PJP, that is something we need to talk about in care of the patient with HIV, but we really wanted to weave in the concept of people using traditional and complementary medicine, and then we thought that perhaps in this module we could incorporate that. So as far as going through the module a little bit, it is, again, the goal is to prepare learners to provide person-centered care for a patient who has an OI, who's interested in this. And we're really, again, trying to model respectful communication and reflective practice. And in the case, there's a 44-year-old man who initially presents to a rural triage clinic with initially sort of subacute symptoms over the past 3 weeks, but then with an acute worsening, which is what prompts him to come in. And then throughout the course of the case, it becomes later evident that although he completes his treatment for PCP, he is not taking his ART, and that is something for the provider or the learners to work through. And Cheyenne, next slide, if that's okay. And so the way the rest of the module goes is that initially we ask the learners to identify the most likely diagnoses of a patient with HIV who comes in with respiratory distress. And we're really trying to, again, make sure that the learners take away the fact that PCP is not usually the most likely diagnosis, that rather it's bacterial pneumonia or pulmonary TB, and that PCP is less likely, but still something to consider. And it just so happens that in this case, that is the diagnosis, but we're really trying to make sure that the learners don't think that it is, that respiratory distress in a person with HIV is usually PCP. So once they've made that differential diagnosis, we then ask the learners to describe a diagnostic approach. And we recognize that not everybody has every modality available. So we ask that the learners consider, how would you diagnose this if you had everything available? And then we also then say, okay, if you didn't have all of these lab tests available, how would you make this diagnosis? And in this case, we make it so that a chest x-ray cannot be obtained that day. And really the only way that the diagnosis is made in this rural triage clinic is through an ambulatory oxygen monitoring, where the patient does have an ambulatory desaturation. And so the decision is made to begin treatment for PCP based on the history and what they have come up with so far. So once that diagnosis is made, the next part is to decide on medications to treat this patient and to describe a therapeutic plan. So we ask learners to think about, how do you do prophylaxis for PCP, and then how do you do treatment for PCP. And specifically, we want the learners to figure out how to dose cotrimoxazole. And so we give them the patient's weight. There should be resources that are given to them as well, and have them calculate the dose of the cotrimoxazole for treatment of PCP for this patient. And then we also talk about steroid treatment for PCP and have the learners come up with the dosing for that. So then after that is done, the patient leaves, gets better from his PCP, finishes his cotrimoxazole, but then comes back to the outpatient department, and 6 months have elapsed, and his viral load is still detectable. And it becomes evident that he is not taking his ART and is instead seeing a traditional healer. So here we ask that there's a role play where we ask the learner, one learner to play the provider and one learner to play the patient. And have them do a role play trying to figure out why the patient isn't taking his medications. Then once that is done, that takes about 15 minutes, and we do want the learners to sort of think about the reasons why a patient may want to not engage in ART. That then we have the learners do a small group discussion about what it's like. And some of the questions that we ask that the learners think about is, have you seen a patient use traditional medicines or a healer before? Maybe what myths and misconceptions have you heard about HIV based on where you come from? To think about where might conventional medical care fall short for this patient and why the patient may be turning to traditional medicine, how this might positively impact his care or negatively impact his care, and so on. And so after the role play, the sort of debrief or reflection is in a small group where people talk about caring for patients who are using traditional and complementary medicine. And then the last big part of the module is to use the 5 whys, which is a QI technique. And in this QI technique, we ask that they are still in a small group, and they take this handout that Cheyenne has nicely taken a photo of. There we go. And use this technique to, again, ask why a problem exists. And the reason why it's called 5 whys is that oftentimes, on average, it takes about 5 whys or asks until you can identify that it's a problem, or until you can identify the system's problem. So for example, in this case, if we say that the patient was off ART for 6 months, you'll ask, why did he go off for 6 months? And then say, okay, because he wanted to use traditional medicine. So why did he want to use traditional medicine? Because he was suspicious of the medicines prescribed. Then the next question comes from, okay, why was he suspicious of the medicines prescribed? And then you could say nobody discussed the medications prior to discharge and he was just handed them in a bag. Why did nobody discuss the medications or counsel him? It's because nobody knew that they needed to discuss this. And so why did nobody know that this would be a best practice? And it sounds like then, this is just an example, but maybe the root of this problem is that the clinic or hospital hadn't done medication counseling before discharge, and that now this hospital or clinic needs to figure out whose role this would be. And this could be different for every learner, but is just really the focus of this is not for each learner to figure out the reason why, but more to be practiced in using this technique to figure out why something may be happening. And this is, again, I think very important to just reiterate to the learners that this is also that we can achieve virologic suppression and get most of our patients virologically undetectable. And then the last part of the module is for people to reflect and sort of do a little bit of writing. And we'd like them to think about how the session might change their practice going forward, and how the learners might care with a team of other health professionals to care for a patient who is interested in traditional and complementary medicine. So how can we all work together as either a clinic or a hospital to best support these patients? So Cheyenne, if you wouldn't mind going to the last slide. So just to sum up, what learning methods are we employing in this module? We're using a lot of small group discussion. There's a role play, and then there's reflection. And the core content that we're trying to communicate, hopefully we've already discussed, but again, that this is sort of how to diagnose, or what are the things that could be causing respiratory distress in a patient with HIV? How do we diagnose and treat PCP? And then how do we engage with and best care for a patient who's using traditional and complementary medicine? As far as the IPE tools that we are deploying, not so many in this case. So I think it'd be really important as the facilitators to, throughout this module, talk about what are the different roles that people could be using throughout this. So in the treatment aspect of PCP, how can we include the pharmacists to help us out with the cotrimoxazole dosing? When caring for a patient who's using a traditional healer, how do we bring in our sort of more conventional medical care, all the different roles to better support this patient? And so I think that would be a key way to end the module so that we incorporate that. And then the QI method addressed in this module is the 5 whys. And that's about it, Cheyenne.
Thank you, Jihan.
Mhm.
For moving on to 17, I'm just going to pause to review the questions in the chat box. We've had 2 questions about the website. So we did go over the website in last week's webinar. That recording is available in the agenda or the invite that you got for this webinar, as well as our weekly circular. And then as far as the website going live, we expect it to go live today or tomorrow, and all of the programs will be sent login credentials. So now I'll move to module 17. Deborah, can you please check your volume?
Yeah, can you hear me well?
Perfect, thank you.
Great, thank you. Greetings, everyone, and glad that you're joining for this. Module 17 is really looking at care for the pediatric patient with HIV. And I think the context for this is that the data across from many countries is showing that both pediatric testing and treatment for children are lagging. And there are many, many reasons for this. I think both around kind of missed opportunities to identify the child who's been HIV exposed or positive, and then issues really around lack of confidence, I think, in a lot of providers in testing children, especially little children, small children, and giving big drugs to them when you may not feel that you're an expert in pediatric care. And then there are a lot of family and social issues that are involved always when you're working with kids and families, and hopefully we'll touch on those. The goal really is to introduce learners to the care of the pediatric patient, to walk through issues of diagnosis, medication, and also some of the social and ethical issues that become involved with working with kids. So the case in this situation is a young boy, David, who's 26 months old, and he's brought in by his mother because he's not gaining weight and appears small compared to other kids. The mother says that she was diagnosed with HIV and took ART during her pregnancy. And she had an undetectable HIV viral load at delivery. And the baby was initially also negative. However, she stopped taking her ART after the baby was delivered and did begin breastfeeding right away. So now the baby is brought in for question sort of failure to thrive, not gaining weight. He's tested for HIV, and in this case, the rapid antibody test is positive. So maybe moving on to the next slide. I think thank you. The first objective really is to sort of review sort of the assessment, pediatric assessment of the child with a particular focus on the child who's been exposed to HIV. I think looking at the domains of growth and development, sort of our kids are where they are plotted against a weight chart. Are they growing? What's their head circumference? The assessment of nutritional status in a child is another sort of an indicator. Sometimes pediatric patients with HIV will have mouth sores or other issues that are making feeding difficult. So just looking at their overall ability to gain weight. And then the developmental milestones were particularly important with pediatric, whether the child is rolling over, whether they have good head control, whether they're speaking their language skills. All of these things point to where a child may be on their developmental path. The activity 2 will actually then translate into sort of plotting some of these out onto growth curves and interpreting those elements. Going back just maybe quickly to some of the physical exam with kids. I mentioned sort of oral mouth sores, looking at respiratory abnormalities. Is there a lot of lymphadenopathy or acromegaly for these kids? A spectrum of things that kind of point to that index of suspicion that if the history, in this case, the history was clear that this was an HIV exposed child and needed a test. But any other child who's coming in, you sort of evaluate them on the spectrum of this complex of presentation. And generally, I think it's recommended if a young child's status is not known and there's a mother status is positive, clearly there would be a test that would be indicated, but also looking at missed opportunities for testing kids whose status isn't known is something to really take under consideration. So moving on to activity 3. This is more looking at the diagnostic picture for infants and children. And a group discussion is engaged on this to sort of question which testing modality would be appropriate depending on the age of the child and the status of breastfeeding. So the groups are asked to sort of think through this and come up with their responses. And there is in resource materials provided a quick guide that if a child is less than 18 months of age and is still breastfeeding, then an HIV DNA or PCR would be indicated, the virologic test. If the child is over 18 months and is not breastfeeding, then the maternal antibodies will have faded out, and you can use the standard antibody test for those children. It is important, I think, always not just to look at the age, but to ask the question about the breastfeeding, because it can kind of skew off the results and how you're looking at them. Moving on to pediatric dosing of ART. There's a lot of issues here. I think countries there are different protocols, national protocols around pediatric treatment and which regimens are recommended. I think there's a basic NRTI complemented with tonavir, tenofovir, efavirenz, etc. And now dolutegravir is coming onto the picture more with more evidence on weight-based dosing. So on this one, I think there's a discussion around an encouragement to look at the national guidelines, and facilitators may wish to introduce that into this case. But basic principles around pediatric treatment, looking to use the fixed dose combinations as much as possible, and recommending the dispersible tablets or granules instead of trying to use the oral formulations of syrups, which are I think a little bit harder to manage, and some require refrigeration. The key point also to bring apart is the importance of weight-based dosing for children. Their weights change, their appropriate dosings will change. And here's a place, I think, where the pharmacist has a role in supporting and advising the clinician going forward if there are questions around this. But I think the WHO has charts that look both at the ART regimens and the weight-based dosing, which are good references to be aware of. Also, in addition to the ART, the facilitator and the group will also discuss what is appropriate prophylactic therapy for pneumocystis pneumonia, for example, in terms of children by age, again, what is an appropriate therapy. Children under 5, we use a CD4 percentage as a more accurate assessment of where they are in their immunologic status. Over 5, I think you can then go back and use more reliably, I guess it's from 6 years on, the CD4 count is a more acceptable measure, I think, of immune status. Comotrimoxazole obviously is one agent, then looking at the status of potential TB exposure, and ruling out whether there's a suspect either in the family history or in the child's presentation. And if not, if the child is over 12 months of age, then TB preventive therapy is something that should be strongly considered. So again, this one is a little bit, I think that the main principles of weight-based dosing, of simplified regimens if possible, and also looking at the national protocols would be important in reviewing this case. On activity 5, I think, again, looking aside all the issues of sort of managing to get the doses into kids' mouths, and the issues of how the burden it is on parents to sort of manage the complexities of ART dosing, there are a lot of issues, I think, that come up in pediatric care that can impact adherence or ability to stay with the regimens. And if you look at the issues that many of you, I'm sure, have seen that confront families, both in getting an HIV test for their child, accepting an HIV test, are the issues surrounding disclosure and confidentiality, both within the family, within the neighbors, within schools for the older child. A fair amount, the levels of stigma that adults experience translate to children as well. There can be a lot of anger between caregivers, between parents around an HIV status of a child, that I think there's a lot of sensitive listening to be done, and to just understand. There's issues of again, poverty, of getting to and from exams, coordination of schedules for a parent who needs ART and a child who may need ART. Looking at sort of all the surrounding issues and being sensitive to those, and asking sort of engage the learners in thinking through issues that would challenge adherence, issues that how do you support parents in their role? How do you deal with the angry child or the toddler who's having trouble taking his medicines? How can you support the parents as they work through these issues? And then disclosure, often a little bit for the older child, but there are issues with disclosure, I think, not to minimize as children reach early or middle childhood. And what is a time or a way in which to share information. And this, again, is very context specific, but I think it's important to have that discussion with the group. Activity 6, it builds on this, sort of what kinds of support are available within the household, within the community for parents. The siblings of the children also come into this picture as well. So it's encouraging the learners to understand the social and environmental situation, both of the family and the communities, and any resources that are available in the clinic that could be drawn upon. There's a bit of IPE here, I think, where you look at multiple sources of support to families, including other families with children who are living through this as well. And sometimes peer support groups have been helpful to parents as they go through this. And I think the last activity I've mentioned briefly, but is the issues of disclosure, how health providers can support a child, support parents in disclosing an HIV status. In this case of a 26-month-old, this isn't as much of an issue for the child as it is for the parents within the family itself, within the extended family or neighbors. And the choice whether or not to disclose this and how to, I think, are issues that are commonly challenging for providers to work through. So engaging, I think, in a larger discussion that in the end sort of maximizes both the benefits for the child's health and supports the family are key to this. So if the next slide, I think, is maybe just a quick review. This is looking at some of the resources that will be available as additional materials, learning how to plot the growth curve, seeing where someone's falling, if they're under the 10% percentile or they're more on target for where you would expect them to be in their development. These may be more tailored to country specific. I don't know the extent to which these are available. These are sort of standard WHO ones for the African continent, but there may be differences across the individual countries. So accept this as a standard kind of a guide. For boys, there's a similar one for girls as well.
Sorry, Deborah.
That's okay.
And actually, while I'm getting back to the right slide, I'll add that we received feedback on needing to know about these charts for girls. So in the additional materials, we have in the references, we're providing the link where people can go to the WHO site and actually explore a lot of other charts in addition to the 2 that we provided.
Excellent. So the methods, what learning methods we're employing, I think similar to really the role of role play, of small group discussions, especially, and reflection, particularly as it addresses some of the psychosocial and environmental challenges that families and children face. But putting yourself in the role of either the patient, the mother, or the provider in sort of working through these issues would be something that I think we hope the learners will do. Core content, again, I would say it's really the identifying the HIV positive child, knowing the appropriate testing and treatment interventions that can make all the difference, especially with the young child. I think we know that the peak mortality is very early on in the first year of life. So looking at and being aware where you're seeing adult patients, it's important to also ask them about their children, to ask about their family. If the parents are benefiting from treatment, you can say, let's make sure your children are fine. If they need it, they can have treatment too. So not missing opportunities there. and then looking at the issues that really that affect the management and support of the HIV positive child and family. The IPE tools, again, sort of using vignettes to explore roles and recognizing that multiple players, I think, are involved often in the care of children. There's a role for the laboratory specialists around what diagnostics may be available. Is this a place where the point of care EID is optimal or available, and that you have an immediate turnaround of result? If there's if there's a need for transport to a specimen to a distant site, the important piece is how to get the information back as quickly as possible to the provider so that they can take the appropriate steps with the child and the family. And I think also the pharmacy clearly around which medications, drug interactions, and dosing for children is there. Pharmacists can be a real resource as that, as well as sort of the support in the community and within the clinic or the broader community for assistance. So this is a very quick run through. There's hopefully we'll have available to you both the facilitator guides and the learner guides, which go into a lot of this more in depth. But thank you, and over to you, Cheyenne.
Thank you, Deborah. That was wonderful. If there are any content questions, please feel free to put them into the chat box, and we can use the remainder of the call time to answer those. In the meantime, I will...
Hi, Cheyenne.
Hi. Is that Judy?
Yes. I apologize for interrupting, and sorry I joined late, but such an interesting topic. I just wanted to add something to Deborah's excellent presentation, perhaps just for information of everyone regarding especially pediatric HIV. I'm currently in Sierra Leone just doing some work around this, and I think this is so critical, and it's, I think, one of the modules that we really need to focus on, especially when we look at the HIV pandemic in our continent. One of the key things I think that needs to maybe come out very more is the issue of disclosure to children, which is still a big problem in many of our African countries have experienced this. And I think the bringing in of, for example, child counselors in this particular IPE framework would be very critical because there's a way they know how to manage disclosure, especially for the younger children, where many times parents, due to stigma and discrimination and sometimes just ignorance, are not able to or don't want the disclosure to happen. The other thing I think that's critical to remember also is to use the country guidelines regarding the pediatric dosages and the pediatric drugs that are required, especially I think for me at birth. So we need to know what the protocols are, and I think one of the learnings around this should actually be to look at the country protocols. For example, here in Sierra Leone, the country hasn't moved to dolutegravir. For example, they're still using the tenofovir, lamivudine, and efavirenz combination. So it's critical to know what the national policy around pediatric dosing, and on top of just the drugs themselves, also to just know the way we give the treatment. So for example, many mothers will give birth, and at birth or during labor is when perhaps an HIV test is done, and then you find perhaps the mother is HIV positive, and at that point you need to know now what do we do with the baby immediately the baby is born and moving forward. And that's not just the drug regimen, it also includes the what is this I want to say, the CD4 and the PCR testing, if they're done at 6 weeks, or the protocol, the algorithm for when these are done. So at birth, what happens immediately after birth, after 6 weeks, and the interface also with the vaccinations for the children. I just wanted to highlight this. Thank you for listening to me.
Thank you, Judy. And I think that I can make the comment that when we received feedback on the version 1.0 modules, a lot of people provided specific guidelines to their country. And so we in turn added sections to the modules called additional facilitator guidelines, where we welcome facilitators to use their own country guidelines, recognizing the WHO guidelines are not standardized across countries. And then exactly what Judy is saying, like, you know, in her context, like the issues that are most critical, this is where the role of the facilitators can bring those issues out. And then speaking of version 2.0, we are working on getting those on the website by the end of the week, but I will put my email into the chat box. And as they are packaged and ready to go, if they would benefit you to have modules before Friday, you can send me an email with your module numbers, and I will try to get those to you. With that, I will move to the end of the slides. So you may have heard that our plan is to continue doing these webinars on a every other week basis. So we will not meet next Tuesday, but resume on October 15th. And it's during these webinars that we'll continue to have be in conversation with one another, sharing best practices, and also the UCSF team can share updates with you all. So thank you very much for joining. And just looking at the chat box now, Judy, Deborah's thanking you. Deborah says it's an excellent point that early infant care at birth and guidance for mothers and caregivers is important to review. So thank you, everyone, and have a good evening.
Thank you, Cheyenne. Thank you, Deborah. Excellent call. Thank you.
Thank you.